All right, thanks for that kind introduction, Eric, and thanks to Sasha for setting up a nice primer for everybody as I talk about transthyretin as the protein that causes TTR amyloid. You know, before I get started, I think it's important that Sasha ended his slide with that multidisciplinary team that we have. Our relationship with amyloid patients actually started with one patient that had AL amyloid that was introduced to me for consideration of heart transplant, and taking care of that patient was such an experience in terms of learning about amyloidosis, both AL and TTR, and getting her through her course of chemotherapy, stem cell transplantation, listing for heart transplantation, recovery, and eventual delisting from transplant for heart transplant was a remarkable learning experience, and that's how we became involved in taking care of these patients with AL amyloid. And subsequent to that, we've been taking care of a lot of patients with TTR, and I'm really going to focus my comments on that particular disease. So, as Sasha alluded to, TTR amyloid is a condition where there is deposition of a particular protein, as the transthyretin protein. I'm going to refer to it as TTR, just because I'd really struggle with long words. But everybody has this protein. It has a physiological function as a chaperone protein. Transports thyroxine and vitamin A. It's synthesized by the liver, and it has an ability to aggregate into amyloid fibers or fibrils, which deposit into a variety of tissues. Primarily, those tissues appear to be in the nervous system and the heart. Both the wild type and mutated forms are able to misfold along this pathway, which is in the schematic down here. So, generated in the liver and moving along, it forms a tetramer, which then can dissociate and then misfold into proteins that aggregate into smaller oligomers and then fibrils that deposit into various tissues. The wild type form that all of us have can misfold into the amyloid configuration, and that deposition almost exclusively occurs in men over the age of 60, and it's often referred to as the senile form of amyloidosis. The various mutant forms, and there are many single point mutations that have been identified. The three most common here in a Mayo experience are shown on this table, have some variability in terms of the tissues that they target. So, for example, the T60A mutation has almost equal deposition within cardiac tissue and the nervous system, whereas the V122I mutation, which is common in the African American population, as Sasha mentioned, is almost primarily deposited within cardiac tissue. And carriers of the mutation itself have a greater than 50% higher risk of development of heart failure. So there is a spread in terms of the degree to which these mutated forms deposit within the nervous system or in the cardiac tissue, but a good proportion of these mutated forms do lead to a cardiomyopathy. And as was mentioned, they really lead to a restrictive cardiomyopathy. So deposition within the cardiac tissue leads to not only direct fibrosis, but also ischemia within the microvasculature, which then leads to cardiac damage, and restrictive hemodynamics, which for the cardiologist lead to really predominantly right-sided symptoms. So elevation in the neck veins, ascites, edema, and very seldomly do patients come in complaining of dyspnea. They actually complain a lot of swelling. It's one of their primary complaints when you meet them in the clinic. They have elevated natriuretic peptides due to direct injury or stress in the myocardium, and that not only is that a marker for disease, but it also has a pathologic role in the development of congestion. These natriuretic peptides that are released are not as effective when released in high quantities, and often referred to as junk or junk BMP or natriuretic peptides that don't have a good physiological effect in the kidney. This leads to persistent congestion, and attempts to diurese them. These patients, for their symptoms, can lead to hypertension. Importantly, there's not been a clear association between the genotype and the degree of heart failure or heart failure-related prognosis. So identifying the genotype doesn't necessarily chart a course of the patient with regard to their heart failure. I couldn't get through the talk without at least showing one hemodynamic tracing, so I thought it was important to show this. When we talk about restrictive cardiomyopathy and restrictive hemodynamics, one of the key features is elevation in both the left and the right-sided filling pressures within the heart. So both the right atrial pressure and the wedge pressure are elevated in these patients. There's a certain degree of dependence between those two sides of those filling pressures, so attempts to lower the pressure and relieve the symptoms of congestion can actually lead to overdiuresis in a very rapid manner and hypotension. Importantly, I think it's we often think about this as a progressive disease, but patients typically present very late in the course when there appears to be a certain amount or a required amount of amyloid protein that's already deposited within the myocardium. So the functional status declines as the amount of myocardial infiltration increases, and we often see patients who are quite symptomatic with New York Heart Association class 3, class 4 symptoms with a declining ejection fraction. It is rare to see these patients with early New York Heart Association class symptoms and without structural effects on the heart that are visualized. Identifying cardiac amyloidosis is hard. I think all of us have seen patients who are towards the end stages with a history that suggests that it could have been identified earlier, but it is just a difficult thing to do, and you require a high index of suspicion. Some clinical clues in their history include a history of polyneuropathy and carpal tunnel syndrome, often bilateral. I was surprised that I thought that was something that was only in the textbooks, but as I've seen more of these patients, there's a clear history that early carpal tunnel syndrome, often bilateral, is a clear marker for investigation of their cardiac status as it relates to amyloidosis. In patients with preserved ejection fraction and heart failure, I think especially in the absence of hypertension or ischemia, looking for amyloidosis is of utmost importance. And often these patients are evaluated first for AL amyloidosis, and when that evaluation is negative, that's when patients are referred for evaluation for TTR. And the most important identifying feature is imaging. That's an example from one of the patients that we've transplanted, and you see on the left in the parasternal long axis view, the left ventricle is at the bottom here. You see a very thickened myocardium, the septum is thickened. The function itself does not look to be that reduced. Right ventricular function also looks quite preserved. In this apical foreview, where the left ventricle is here, right ventricle, right atrium, left atrium, you again notice, is that still playing up there? There you go. Let's try again. I'll just leave it alone. The septum is again thickened, and I think one of the key features here that I've learned from our echocardiographers is that the motion of the heart, especially at the level of the valve, the tricuspid and mitral valve annulus, is diminished from base to apex. So that movement of longitudinal shortening of the heart is reduced, and that may actually turn out to be a early marker for infiltrative cardiomyopathy more broadly, not necessarily just for amyloidosis, in patients who are presenting with heart failure and a preserved ejection fraction. Cardiac MR is going to be talked about, I think, later in the day. But cardiac MR technology actually provides exquisite images of the myocardium. And in patients who with suspected infiltrative cardiomyopathy, it's become our practice to look with cardiac MR for a variety of diseases, not just amyloidosis. But there is a discrete pattern of infiltration and a scar pattern that is in a non-coronary distribution within the heart, which is shown at the bottom left. Our group here with Ray Kim's leadership has shown that the degree of scar or hyper-enhancement by cardiac MR actually has prognostic value depending on the degree of hyper-enhancement. And later on, I think we'll hear about how how one can actually distinguish between AL and a TTR amyloid using cardiac MR technology. So, as was mentioned, both in AL amyloid and TTR amyloid, prognosis is really defined by the functional class, the hemodynamics, and the degree of elevation in natriuretic peptides, as well as troponin as a marker of cardiac injury. The typical course, as I mentioned, is one of congestion, progressive pump failure, often hypotension. Arrhythmias are also noted. Bradycardia has been seen in some small series as a cause of death, particularly for TTR amyloid, and it probably is reasonable to consider a pacing device for treatment of these patients if there is evidence of a conduction disease on their baseline EKG. Ventricular arrhythmias are less often seen with TTR amyloid in the best series that we have, and far more observed in AL amyloidosis. And it appears to be a limited role for primary prevention ICD, especially in those with a relatively preserved ejection fraction. And so overall, there's been patients with infiltrated cardiomyopathy in general and those with amyloidosis have had a often poor prognosis compared to other causes of cardiomyopathy. And this is a study that was done by one of my partners, Mike Felker, back in 2000, where biopsies were done on all patients seen in the Hopkins Cardiomyopathy Clinic, showing that cardiomyopathy to any infiltrated disease in a certain portion of these patients did have amyloidosis, was quite poor relative to other non-ischemic and ischemic heart disease. Are these all?
I wonder whether you should maybe close it down and restart.
Yeah, let's do that. That's right. Let's see if I try that again.
Reset the HDMI signal.
Sure. I can't draw these pictures, or else I'd. How's that? We can go. Scroll to the. Let's try there. Is that better? Yep.
Yes.
Maybe not. Switch it up, or do you want to leave it?
She says hers is working. Let's give it a try.
All right.
Can you unplug the HDMI cable?
Well, while he's getting ready, I mean, I'll make a comment just to a point that Chet referred to, and I think we've noticed increasingly commonly. We're going to hear from Dr. Hundley, who is a national expert in MRI soon. But in our experience, you have to think about this disease before you get very far, and it's very insidious. And we have noticed in our cardiovascular imaging labs, particularly in our echocardiography labs, where we do a lot of strain-based imaging now is routine, that we're capturing a lot of individuals with abnormal strains that have patterns that suggest what Dr. Patel mentioned, the issue of really apical preservation of function and basal abnormalities, which is very unusual, unrelated, would never be seen in ischemic heart disease, but is to us a telltale sign that we need to investigate it. So as more and more labs become more proficient at using strain, I'm hopeful that will lead to increasing screening opportunities. So.
Yeah, and I think that decrease in longitudinal motion really speaks to the restrictive hemodynamics. And we often get asked whether mechanical devices could actually help patients who have worsening heart failure with amyloidosis, especially if they start developing a decrease in their cardiac function. Overall, the experience with devices such as left ventricular assist devices or LVADs has been quite limited, mainly because these devices are designed for univentricular support. And so they can support the left side of the circulation, but because of the restrictive hemodynamics caused by amyloidosis within the heart, the patients are left sometimes with persistent symptoms of right-sided heart failure. And there's been a series out of the Mayo in patients with restrictive cardiomyopathy, included 10 patients with amyloidosis, and suggested nearly around a 60% one-year survival. But most, if you take a deep dive into that data, they had persistent right-sided symptoms and important morbidity throughout the course of that year. Heart transplantation is offered in select cases for TTR amyloid. As was mentioned, a lot of these patients are older, they present later, and may not be offered heart transplant due to advanced age and other comorbidities. There's far more data available for AL amyloid and other restrictive cardiomyopathies, but the best data available in terms of a large number of patients is out of the heart transplant registry database, and suggests that patients with amyloid cardiomyopathy here in the blue did have worse survival after transplant than other diagnoses. However, if you look only at those that had restrictive cardiomyopathy and compare those to patients who had amyloid, survival rates were reasonably successful after adjustment. So it is a possibility to replace the failing heart that has been affected by amyloidosis with a cardiac allograft. We have some of experience here. Dr. Rogers has had interest in transplanting patients with amyloidosis for some time, and in the last 5 years, we've transplanted 4 males with TTR amyloid. There's been a 50-50 split with either wild type or a mutant form. These patients were between 65 and 76 years old. Our oldest transplant patient to date has been 76 years old. Had limited comorbidities or clinical evidence of extracardiac disease. And they had primarily cardiac symptoms. These patients did not have prior cardiac surgery, had minimal pulmonary hypertension, and really relatively preserved renal function despite their age. They were supported with inotropic agents until transplantation, and at least intermediate-term results suggest minimal evidence of involvement in the transplanted heart. We have seen extracardiac manifestations that have been progressive in 2 of these cases, GI and neuropathic. So it is a possibility, and we have transplanted patients with TTR amyloid at our program. It's important to identify those patients that are sliding before transplantation, and these are data out of the transplant registry again. And the important point here is that as patients decline and require mechanical devices before transplantation, their post-transplant outcomes are worse. You add that to a patient who has a systemic process that could affect other organs or at an advanced age, and we could have less success with heart transplantation unless we identify those patients earlier. And it really does speak to having that high index of suspicion and finding patients earlier in the spectrum of their heart failure that are affected with amyloidosis. And recently, there's been some recognition of amyloidosis in our cardiac allocation scheme for transplantation. This is a proposed scheme that is up for public comment. Dr. Rogers actually chaired this committee, chaired the thoracic committee for this, and there's been specific recognition of amyloid as a distinct clinical entity for heart transplantation. So with other restricted cardiomyopathies, other infiltrated diseases, and actually congenital heart disease. So it will be the opportunity at least to list patients for cardiac amyloidosis as their need for heart transplantation, which is not the case right now. Sasha mentioned source control, and I described to you in the opening comments that the source of this amyloid protein is actually the liver. So liver transplantation has been looked at as a method for source control to reduce deposition of this mutant protein, either mutant protein or wild type protein in tissues. The experience has been primarily in the V30M mutation, which has significant neurologic involvement over cardiac involvement. And what is known is that neuropathy and organ involvement are not necessarily reversed, despite quite good survival rates. But interesting, there seems to be evidence of TTR developing on a substrate of mutant TTR deposition. What I mean by that is organs that have been affected by the mutant form prior to liver transplantation, even with a wild type, a liver transplanted that's producing wild type TTR, they appear to be predisposed to developing amyloidosis within those organs. So liver transplantation, although an option, does have its limitations, of course, not including the availability of organs. So what's really exciting about this is that so far what I've told you are two therapies at the end of a spectrum. Source control by removing the liver and replacing it with a liver that does not produce a mutant protein, or heart transplantation by replacing an organ that involvement of which limits survival. But there appears to be a lot of space in between where novel pharmacotherapy might actually be playing a role. And recently, there have been developments in agents that may actually mitigate development of amyloid fibrils and their deposition. And these work at different stages along this schematic here. So, gene silencing therapy. As I mentioned, the protein itself, the tetramer, is actually developed in the liver, and some antisense oligonucleotides, or ASOs, have been developed that inhibit expression of TTR. This is either within the nucleus itself through transcriptional interference, or extranuclear with silencing RNAs. And there's currently a phase 2/3 randomized control trial with this company with an unfortunate name in familial amyloid polyneuropathy. So primarily in those patients that have a neurological disease related to amyloidosis. A silencing RNA to inhibit translation of this mutant protein is also in trials with another endpoint of neuropathy. The TTR protein itself is produced as a tetramer and then destabilizes and forms monomers that then misfold. So the ability to stabilize this tetramer might be a valuable way of stopping deposition upstream of the actual target organ. In the past, an agent, diflucinil, has been used, and that's been shown to reduce progression of neurological impairment. Diflucinil is an NSAID, and has quite good data for reducing deposition within neurological tissue and symptoms of neuropathy. There's actually limited data for reduction in cardiac involvement, but in our practice, this has been one agent that we've used to try and stabilize TTR and reduce deposition in patients who have both neurologic involvement and cardiac involvement. Tafamidis is actually a novel compound that targets the binding sites, the thyroxine binding sites of the TTR tetramer. It inhibits dissociation to the monomer that then misfolds, and in the V30M mutation actually stabilized the tetramer and slow progression of neurological function. There's actually a phase 2 trial assessing the progression of cardiomyopathy, and on the right we see some markers of cardiac involvement that, at least in the early phase after initiation of the therapy, showed a decrease in natriuretic peptides, troponin, and troponin markers, both I and T. Those investigators went a little bit further and actually looked at functional data and in patients who were treated with tafamidis, showed that functional status actually improved early after initiation of therapy, but then did worsen over time. So based on these data, there's an ongoing phase 3 randomized controlled trial with 2 different doses in patients with known TTR cardiomyopathy, biopsy-proven TTR cardiomyopathy, with endpoints of all-cause mortality, frequency of cardiovascular-related hospitalization. And they're also looking at functional and quality of life status as secondary endpoints. The last step is degradation of the fibrils. So removal of the deposited TTR from the organs that are affected. In the past, agents such as doxycycline and TUDCA, in combination have actually have shown limited progression of disease, shown to limit the progression of disease, and there's an active phase 2 study ongoing. There are actually monoclonal antibodies targeting amyloid protein in preclinical testing, and as you put all this together and you look at TTR amyloidosis as a disease that starts in the liver and then targets other organs, but there are many steps along the way. The future may hold a multi-targeted approach, not only trying to limit production of the monomers, but also limit deposition, actually remove deposition from targeted organs. And that will provide another adjunct to our therapies, and not limited to just to transplantation. So in summary, TTR amyloidosis involves the heart in the vast majority of patients. Recognition and presentation are currently typically late, but novel imaging techniques combined with a high index of suspicion may actually allow earlier detection, and could be critical in identifying and treating patients earlier in their disease course. Heart transplantation can and is utilized in select cases, and some of our emerging therapies really provide the opportunity to tackle the disease at multiple levels. And I thank you for your attention, and sorry for the technical difficulties.